Hello and welcome to Arbor Rehabilitation's Home Health PDGM 201 webinar. This is part one where we're going to be looking at the admission source and ICD-10 coding a little more specifically. This is a deeper dive into the PDGM qualifiers and a recipe for success. This is Cindy Hudson and I'm the Director of Clinical Compliance with Arbor Rehabilitation. I thank you for your time today for just a few minutes here. We're going to do a quick overview of the recipe. We know we have these four main ingredients from the admission source, the clinical grouping, the functional impairment level, and the comorbidity adjustment. Remember, payment is based on the person's HERC score, and that score is composed of their admission source and timing, the clinical grouping based on the ICD-10 coding, the functional levels or functional status from the M1800 series of questions on the OASIS, and finally, it looks at their comorbidity scoring, which also comes from the ICD-10 coding. So only one OASIS area now is going to impact the HERC score, and that's from that functional impairment level. That's the only piece of the OASIS data that's going to pull over onto the claim to help influence that HERC score under this new payment system. So we're going to look at the recipe. The first thing we're going to talk about is the admission source, and that can either be early or late, institutional or community, depending on the situation. An early admission is within that first 30-day period. Late is the second and subsequent 30-day periods in a sequence of home health periods. A late 30-day period is always classified as a community admission unless there's an acute hospitalization in the 14 days prior to the late home health 30-day period. When you think about that, that kind of only makes sense. Whether or not a person is a community or an institutional admission is going to depend on what healthcare setting was utilized in the last 14 days prior to the home health admission. Where have they been? There was some rumor on the street that people were hearing that home health agencies were no longer going to want to admit people from the community because institutional home health admissions weighed out a little bit greater and had better reimbursement. But when you think about it, it makes no sense for that rumor to become any kind of reality, because number one, that agency would not have a good reputation in the community for not taking in those people in the community who need their care. And it would be a huge red flag to CMS that there's a lot of people that are in this home health agency that did not come from the community. So I think any agency that's going to do that is kind of on a slippery slope. Hopefully we won't see that in any of our practices. The impact of the admission source, we're going to have those agencies help us determine the actual admission source information. They may have better intake data than what we're going to see. So they're going to help us with whether or not it's early or late or community or not. Just to be aware, claim rates can vary by as much as $800 to over $1,000 per claim based on the admission source and the timing. And a gap of 60 days is going to restart that calendar. They're going to get a new early period if they've been out of the system for 60 days. But be aware that claim rates varying as much as $800 to over $1,000 means it's going to be real important for us to make sure we've got good information communicated with the agencies. If we hear something different from what we might think is what the agency thinks is going on, we need to make sure that we alert the agency so they can make those appropriate adjustments. When we look at the rest of the recipe, we're kind of combining the second and third ingredients because these are going to be both involved with the ICD-10 scoring or ICD-10 coding. We need to be absolutely certain we're capturing all appropriate ICD-10 codes because they can significantly impact clinical grouping and the comorbidity designation. So those are both going to factor into the HERC score and therefore the reimbursement category. We want to make sure we're doing very thorough chart reviews so that we capture all relevant ICD-10 codes. It's going to be so important at this time because half of our recipe, clinical grouping and comorbidity, makes up half of our recipe for that HERC score. So we've got to get it straight. We've got to get it right. The principal diagnosis reported on the home health claim is going to place the person into one of 12 clinical categories, and it needs to be that primary reason for the home health services. We know sometimes you have a lot of choices when you're looking through the history and everything that's been going on. It's been pretty complicated course for some individuals, but we need to choose really wisely what's going to be that principal diagnosis that gets on the home health claim that's going to dictate the rest of what that clinical category might look like. We may not be the one completing the OASIS, we're certainly not the ones doing the claims, but we are certainly the ones who look through the chart, gather some medical history, and can contribute some good specific ICD-10 codes to our agencies. When we look at the breakout of clinical grouping, we have areas that you've seen before, neuro rehab and wounds, complex nursing interventions, musculoskeletal rehab, behavioral health, and so forth. MMTA, those are medication management, teaching, and assessment. And anybody who falls into one of those categories may still need our services. Another rumor on the street that I heard is that some agencies perceive that if they're not into either musculoskeletal or neuro rehab, that they won't qualify for therapy. That's just absolutely not true. Certainly people who've had surgeries or cardiac issues, respiratory issues, and so forth, they do need our care. So we should be involved with those people as well. Dispelling the rumors here, I guess we're saying. With clinical grouping, some base payment rates, just to at least let you know what the base payment nationwide looks like. This is not specific to any one area. It doesn't factor in any of the other considerations. But somebody who's in the neuro rehab category, for example, their base payment rate is $1,466. Compare that to maybe somebody who's had surgical aftercare, MMTA aftercare, surgical aftercare. Their base payment rate is $943. And then there's a range in through their wounds. That's another high one for $1,567, because those are resource intensive individuals. So it makes sense that they're going to be reimbursed on a higher, with a higher base. We need to, again, just another reason why I'm bringing this point up, we need to do really careful chart reviews, capture the best ICD-10 codes that we can, because if it's going to shift them from one category to another, that can have a huge financial impact. We know that the agencies are going to favor their partners who help them be the most financially successful. So we want to help them partner with them as well to the extent that's clinically appropriate. We need to know that not all ICD-10 codes are going to count. So there is something called a QE or a QEC code, which is questionable encounters. And per CMS, these codes are going to result in $0 of reimbursement if they're used as a primary diagnosis. So the questionable encounter codes can be used as a secondary diagnostic code, but it will not impact reimbursement. Typically, we're going to recognize those questionable encounter codes because they're vague. In their definition of an ICD-10 code, it might say things like other or unspecified. It might be a symptom code, but it's not an actual defined diagnosis. So it makes sense that these are questionable encounters and they're not going to result in reimbursement if they're used as a primary. We want to scour the chart, look for something more specific, or if it's not there, consult with the agency. Maybe during the face-to-face, they can find something more specific and appropriate so that we don't end up with a $0 reimbursement. The system also is going to look at comorbidities. That's going to be another part of the ingredient for good HERC scoring. So fortunately, per CMS, they consider a comorbidity being defined as a medical condition coexisting in addition to a principal diagnosis. It's tied to poorer health outcomes, more complex medical needs and management, and higher healthcare costs. We know that. We've seen this all along in our practices, but it's really nice that finally CMS is recognizing this and factoring it in to the HERC score, to the reimbursement rate. So comorbidities are going to be specific to home health. And it was a list that was developed by CMS with some pretty broad categories used to group those comorbidities that would count within the PDGM system. As you look over this list, it looks really similar to the clinical groupings categories, and it does. But there's two extra ones in this area that's looking at neoplasms and renal disease, which is not necessarily accounted for with the clinical groupings. But when we see comorbidity diagnosis, ICD-10 codes that link to any of these areas, make sure we get them accounted for on our documentation and the agency is aware of them. So a home health 30-day period of care can receive a comorbidity adjustment under the following circumstances. Number one, there may be no comorbidity adjustment if there's no reported secondary diagnosis that falls into the low or high comorbidity adjustment categories. Low comorbidity adjustment is when there's one reported secondary diagnosis that's associated with higher resource use, or there may be a high comorbidity adjustment when there's two or more secondary diagnoses that are associated with higher resource use when both are reported together. Compared to if they're reported separately, meaning in other words, you could take two simple things, but when you put them together, it's not simple. And CMS is recognizing that and making a high comorbidity adjustment for that because it recognizes the interaction of those diagnoses. And that's pretty clever. But we're going to need to rely on the agency software to help us figure out where anything is going to land with these adjustments. Our job is to make sure we get good ICD-10 input to those agencies so that they can factor out whatever is appropriate. Just a tip if we're doing an OASIS. On the OASIS, there's space for 1 primary diagnosis and 5 secondary diagnoses. Not very much. So we want to make sure if we're doing the OASIS, we code the primary, the best reason for why they need those home care services first, and then add in the other most relevant secondary diagnosis. But be aware on the healthcare claim, which we will never be filling out, there's 25 spaces total to list all of the relevant diagnoses. So when we see things that might link to cardio or respiratory or whatever it might be, make sure we get that listed on our information on our evaluations, so that the scrubbers that our agencies might use, the nurses that are looking our information over, can pull that good information onto the claim. As you've seen before, I've shown you some numbers can make a huge financial impact. When we're doing the OASIS, we want to make sure that we're choosing carefully, as I said before, what to put on those 6 lines so that we're picking out the best, most appropriate codes. So a brief recap here, when we look at ICD-10 coding, it can impact the clinical group, which is part of the HERC scoring, part of the recipe for the HERC score, which then impacts payment. Also, as we look at ICD-10 codes, those impact comorbidities, another part of the recipe under PDGM, part of the HERC score, which impacts payment as well. So careful attention to ICD-10 coding, finding what's in the charts, as well as knowing if it's an early or late community or institutional admission. All of that is part of the recipe for success. So this concludes part 1 of our presentation on PDGM 201. We do have part 2 coming up on information for functional levels and LUPAs. Just so you know, here are some of the resources that were used in developing this webinar. And here's some context. If you have questions or concerns, certainly don't hesitate to reach out to any one of these people, and we'll help answer your questions as best we can. Thank you for your attention. Have a great rest of your day.